much for that kind introduction, and thanks everybody for joining on our first session of our grand rounds at CMH. Thanks for Nina and the team for putting it together and for inviting me to present. So, the presentation today is really on looking beyond our traditional risk factors for atherosclerotic cardiovascular disease to address the ongoing epidemic of ASCVD. And we'll talk a little bit about some of the novel factors that have been identified. These are my disclosures for this presentation. I think the most important one I should disclose is that a number of the clinical trials that we will be talking about I've been fortunate to be a principal investigator on. So that does bring bias, and I'm cognizant of that, but hopefully it also brings a little bit of insight as to how that fits into our algorithm of understanding ASCVD and how to go about reducing the progression. So this morning we're going to talk briefly about the demographic trends in ASCVD, the impact of traditional risk factor modification strategies that we've deployed now for a few decades, but review also the residual risk despite a guideline-directed medical therapy, and specifically review the impact of novel risk factors like lipoprotein A in ASCVD, the impact of obesity and its impact on both vascular inflammation and progression of atherosclerosis, and interventions that are being developed or have been studied in vascular inflammation, as well as briefly review the epidemic and marked increase in cardiovascular disease in women in particular, and perhaps some of the unique risk factors in women that we need to think about when we try to assess their risk for cardiovascular disease. So to begin with, we're going to just briefly talk about the fact that I'm no longer talking about CAD, I'm really talking about ASCVD. And we've gone away from talking about coronary artery disease and talking about atherosclerotic cardiovascular disease, or ASCVD, because we've understood that the processes that lead to coronary atherosclerosis and MIs are the same processes that lead to cerebrovascular disease and stroke, as well as peripheral vascular disease. And often patients present with polyvascular disease, where they will have both cardiac involvement with coronary disease, but coronary patients are at a higher risk for strokes, and in reverse stroke patients are at a much greater risk for coronary disease. And peripheral vascular disease patients are in fact among the highest risk for both MIs and strokes. So the risk factors that lead to these processes are systemic, and fortunately the interventions that we can deploy for coronary disease prevention also have important benefits in reducing cerebrovascular disease and peripheral vascular disease. So, the good news is that we've come actually a huge distance over the last few decades in our understanding of cardiovascular disease and our strategies to mitigate and prevent disease progression. And heart disease deaths have been falling substantially over the last 3-4 decades. And compared to other chronic illnesses, it's really the one area where we've made the most progress in reductions of atherosclerotic cardiovascular events and deaths from coronary artery disease. And that advance and change has really happened because of a much better understanding of the mechanisms of cardiovascular disease, as well as interventions we can deploy, both public health measures, lifestyle interventions, but also the therapies, as well as procedural and surgical therapies that have really led to the marked decline in age-adjusted mortality in the last 3-4 decades in cardiovascular events. And the majority of our ACS patients, when they're hospitalized, end up with angiography and some form of revascularization, primarily percutaneous PCI, angioplasty and stenting, but also sometimes surgical intervention if they have diffuse disease. And we have shown in various studies that an early invasive strategy reduces the risk of recurrent infarction, heart failure, arrhythmia, and long-term mortality. So the vast majority of our patients that are admitted with ACS should undergo an early angiography and be considered for revascularization. Excuse me. Beyond that, though, we know that opening up that one coronary lesion is not enough. It's a systemic process and a diffuse process. So we really have to change the disease process itself. That involves interventions on lifestyle behaviors, cholesterol reduction, management of blood pressure and the specific role of angiotensin receptor blockers and ACE inhibitors, regardless of blood pressure, as well as the impact of diabetes control. And cardiac rehabilitation is a linchpin in this whole process. As you know, we run the divested cardiac rehab program at my clinic for Cambridge Memorial. And cardiac rehab, I think, is an essential part of our efforts to mitigate and reduce recurrent future events. All patients that have had an MI, have had PCI, bypass surgery, or have been diagnosed with cardiovascular disease should be offered cardiac rehab and encouraged to participate. It's not a gym, it's a chronic disease management program where patients undergo intensive lifestyle optimization through diet, exercise, stress management, counseling, smoking cessation, and receive the support they need to understand their disease and remain adherent to the therapies that reduce recurrent events. And cardiac rehab has been shown categorically to reduce recurrent events by 20 to 25%. Many of our post-MI and cardiac patients suffer from depression and anxiety after a life-altering event like that, and cardiac rehab has been again shown to reduce affective disorders post-cardiac event and return patients back to full life and recovery, cutting recovery time by as much as 50%. So certainly we need to continue to encourage. Unfortunately, cardiac rehab remains underutilized province-wide, with less than 20% of patients that should go through cardiac rehab even being offered cardiac rehab. So, we need to ensure that we do robustly utilize the resources available in our region. But certainly beyond lifestyle, we have learned over the last 4 or 5 decades that there are really 4 traditional pillars of reducing atherosclerotic events. Those include antiplatelets, aspirin or clopidogrel or ticagrelor often, the role of angiotensin modulators, either ACE inhibitors or ARBs, have been shown to reduce cardiovascular events. In the post-MI setting, at least for the first year, beta blockers may have an important role. There's some equipoise and controversy beyond a year whether beta blockers continue to provide continued risk reduction if LV function is preserved. So that is a point of ongoing research and current clinical equipoise. And certainly statins have been a hallmark of atherosclerotic event reductions over the last 3-4 decades. What we have learned from various studies that have looked at the cumulative impact of these 4 pillars of ACS management, that in the first year, if we deploy all 4 of those strategies, as much as 90% reduction in the risk of an MI and cardiovascular death in the first year. And that's really how we've managed to reduce that 1-year mortality, which in the 70s and even early 80s was as much as 25 to 30% 1-year mortality after an MI. Now, in the most recent assessments from the mid-2020s, MI death in the first year is now down below 5%. We're around 2 to 3%. So that is a dramatic improvement in 1-year mortality over the last few decades, really because of these various lifestyle interventions and pharmacological therapy. The question is, how long can we continue to reduce those events? So this is the curve of 1-year mortality. And as you see, both out to the mid-1990s and more recent data, we've continued to see substantial 1-year mortality reduction after an MI. The issue, though, is that after that first year and continuing going forward, there is ongoing residual risk and recurrent cardiac events continue to accrue. And if you follow patients out to about 3 years, the most recent studies would suggest that as much as 15 to 20% of patients will have a recurrent MI, stroke, or cardiovascular death. So while we've done a phenomenal job of reducing that in-hospital mortality with aggressive strategies and mitigating 1-year risk, the risk continues to accrue with time. And that's really going to be the focus of what I want to discuss the rest of today. Unfortunately, in the last few years, we've seen for the first time in Canada a drop in life expectancy. And this predates the pandemic. It started in the We first noticed that mortality or survival started to plateau in around 2015, and from 2018 onwards, we started to see a reduction in life expectancy in Canada. And for the first time, actually, in decades, we've seen an increase in cardiovascular mortality in Canada. So the strategies that we've deployed to date don't seem to be continuing to provide the same degree of protection, and we are seeing an increase in cardiovascular deaths in Canada. The Americans, as with many trends, saw that trend actually a bit earlier. They saw an increase in cardiovascular mortality in and around 2010, 2012 because of the diversity and complexity of their healthcare system and disparities in their system. They tend to have a lot more variability, but they started to see that increased mortality about 10 years before us. And that's now being seen worldwide, that cardiovascular mortality for the first time is starting to increase despite the four pillars of therapy that we've discussed. And so really the future of reducing residual ASCVD risk will come down to, I think, a precision therapy era. We have the four pillars that the vast majority of our patients end up on. But beyond that, we need to start now focusing on phenotypic specific approaches. Not everybody needs to get every therapy, but some people need additional therapies targeting their very specific phenotypes that may be contributing to the progression of their ASCVD despite the traditional four pillars. And when we think about residual risk, we know that statins have been a mainstay of reducing cardiovascular events. But despite that, the most potent statins, atorvastatin, for example, at 80 milligrams, while it reduces residual risk compared to less potent therapies, there is still anywhere between 80 to 85% continued residual risk. So statins are a mainstay of therapy, but not necessarily enough to reduce progression of plaque and cardiovascular disease. The first add-on therapy to statins that showed any benefit was ezetimibe. It's now generic. It's relatively cheap. Unfortunately, it's also relatively ineffective. It has a pretty modest effect, but some effect. After 7 years of therapy add-on to statins, ezetimibe did reduce risk by about 2%. So a modest effect, but some effect on residual risk. And PCSK9 inhibitors have been around now for about a decade, and they've shown a much more robust reduction of LDL with evolocumab, for example, in the Fourier trial that we were a part of. We saw curves separate very quickly. Within the first year, we started to see a reduction in ASCVD events. And by 3 years, we saw quite substantial reduction, so much faster reduction with much more aggressive LDL reduction. And we are now achieving LDLs with PCSK9 inhibitors that are practically in the undetectable range. In the Fourier trial, the mean LDL achieved was below 1 at 0.7. Guidelines are changing. The Europeans have adopted their guidelines to suggest that very high-risk patients should be targeting an LDL below 1. Our current guidelines still suggest an LDL target below 1.8 for high-risk patients. That is a trigger point. If their LDL is above 1.8, additional therapies are required. There's actually no bottom to LDL, and our guidelines recommend that the lower the LDL, the better. But certainly if it's above 1.8, additional LDL lowering therapies should be added beyond statins. But again, even with potent PCSK9 inhibitors, as you can see, there is still a significant residual risk. Even at 3 years, there is a 8% recurrent event rate despite very aggressive LDL reduction. We've known that triglycerides, for example, do contribute to cardiovascular disease. Every populational study has shown triglycerides may in fact be more closely related to the progression of ASCVD and MIs than even LDL. In the Copenhagen heart study, they showed that elevated triglycerides increased MIs and all-cause mortality, as well as increasing strokes. The problem has been that historically, triglyceride-lowering therapies like fibrates, fenofibrate, bisfibrate, and niacin, and other therapies like over-the-counter omega supplements have really failed to reduce cardiovascular events. So while we've known for a long time that triglycerides may contribute to progression of ASCVD, we have not had any strategy that mitigated that risk. until now. So the Reduce It trial came out a couple of years back, and that randomized patients with established cardiovascular disease or high-risk diabetics to staying on their statin, but if their triglycerides are above 1.5, being randomized to the addition of icosapent ethyl versus placebo. And we saw that the curves again started to separate quickly within the first year, and at 5 years there was a 5% absolute reduction in cardiovascular events. And this was the first therapy in patients with elevated triglycerides that showed a significant reduction in ASCVD events. So icosapent ethyl is a derivative of fish oil. It's been altered to be more stable, and the problem with fish oil supplements and over-the-counter supplements is that they oxidize very quickly, and by the time they're actually absorbed, they're neutral compounds and have no benefit. Icosapent ethyl has been altered to be more stable and less prone to oxidization, and in patients with elevated triglycerides, our CCS lipid guidelines would suggest that they should be considered for the addition of icosapent ethyl, and given its significant benefits. But even here you see that there is still a significant residual risk. There's still 25% event rates at over 5-6 years. So we need to now look beyond those traditional therapies. One of the things that is now part of our guidelines is that all Canadians in their adult years should be getting their lipoprotein A checked at least once. As you know, lipoprotein A is a genetically derived cholesterol. It's the most common, actually, point mutation that people can inherit. 1 in 5 Canadians have an elevated lipoprotein A, and lipoprotein A is strongly linked both to the development of MIs and cardiovascular atherosclerotic disease, but also, interestingly, also closely linked to the development of aortic stenosis. And there are ongoing trials right now to see the impact of lipoprotein A lowering therapies on both reductions of MI and reductions of progression of aortic stenosis, which would be incredible if we actually had a pharmacological therapy that could treat or mitigate progression of valvular heart disease. Up until now, valvular heart disease has very much been a watch, wait, and see, and look at surgical intervention to replace the valve. But if we could actually mitigate the progression, that would be an incredible achievement. We know that LPA has dual mechanisms of harm. It is a molecule that is very similar to LDL. It has properties very similar to LDL, and thus is pro-atherogenic, so it causes plaque formation and progression. But it also has an ApoA molecule attached to it, which makes it pro-thrombotic. So not only does it lead to plaque progression, it also leads to thrombus formation on the plaque, which significantly increases its mechanism for harm. It is almost exclusively genetics. It is not altered by diet or exercise or smoking or other lifestyle interventions. And up until now, there have been no lipid-lowering therapies that have been approved to be effective at LPA lowering. So it is mostly genetics. So then that begs the question, if we know that this is atherogenic, it's genetic, but you can't change it, why measure it? Well, as I said, it's strongly linked to the development of cardiovascular disease, and because it's from birth, people have elevated cholesterols, lipoprotein A cholesterol from the time they're born. So that long-term exposure to an elevated lipoprotein A from birth onwards really makes this a much more atherogenic because of its cumulative exposure. And so that really means that we need to treat people with elevated lipoprotein A much more aggressively. That does involve optimizing other risk factors best we can through lifestyle interventions. Even in primary prevention, also did show you data that perhaps we should think about low-dose aspirin in select patients. This may be the one area where primary prevention aspirin may play a role. It is also an opportunity for cascade family screening. It is inherited within families, and we want to capture all of those at risk. But certainly we want to aggressively treat other risk factors like LDL, and there are therapies either currently available or in development that may help to lower lipoprotein A. And we have shown, for example, that lifestyle interventions in patients with elevated LPA, while it does not lower LPA, reduces the impact of LPA. So in this slide, you can see that those that adopted a healthier lifestyle had significantly lower cardiovascular events than those that continued an unhealthy lifestyle, despite the fact that the lifestyle changes didn't lower LPA. So we can lower the impact of it through lifestyle interventions. And we have shown in small trials that perhaps even in primary prevention, because it is a prothrombotic molecule that can lead to thrombus formation, perhaps the addition of a low-dose aspirin in select patients may reduce the risk of MI or stroke. So this may be the one area where primary prevention, antiplatelet therapy with aspirin, may have a benefit. We've failed to see benefits of primary prevention aspirin in diabetics or others without established cardiovascular disease, but the preliminary trials would suggest that perhaps LPA patients may be unique, that because it is a prothrombotic molecule, baby aspirin in that setting may have some benefits. Still to be proven, not part of the guidelines, but certainly if patients are concerned, that may be something we think about. We also know, though, that LPA really crosstalks with LDL. What I mean by that, if you have is an elevated lipoprotein A and you have an elevated LDL, your risk of cardiovascular events is dramatically higher. But if we manage to get your LDL substantially lower through aggressive LDL lowering therapies with statins, ezetimibe, PCSK9 inhibitor where required, we can mitigate much of that risk. There is still a risk compared to low LPA, but we can reduce much of that risk through other risk factor modification strategies. So the way I think about it is if a patient has LPA, I may not be able to lower it, but I need to do everything else right. I need to make sure that their blood pressure is very tightly controlled, that their LDL is as low as possible, that they're working on appropriate lifestyle interventions and smoking cessation and blood pressure, diabetes control. So everything else has to be right because they've been exposed to this atherogenic molecule for so long. And at least for now, we don't have specific interventions. There are no approved therapies for LPA yet. Now, PCSK9 inhibitors and modulators may reduce LPA between 20 to 30%. They do not have a specific indication in Canada for LPA lowering, but we have seen in clinical trials that they do lower LPA by about 20 to 30%. There are a number of molecules in development to lower lipoprotein A, and it's actually very cool. We're now doing gene silencing therapies with siRNA technology, so reverse RNA technology that binds to the RNA, takes it out of circulation, and reduces the production of LPA by as much as 80%. So very dramatic phase 2 results that have recently been presented. The phase 3 trials to look at the impact of that on actual ASCVD progression are ongoing, and at our clinic we're involved in a number of those trials. They should hopefully report in the next 2 to 3 years, and we may have some more things to talk about as potential interventions. So those are upcoming. But certainly with elevated LPA, we need to really do everything else right. The other major thing that's contributing to the increase in cardiovascular events for the first time in decades in Canada is a demographic trend that we're all aware of. We've talked about for decades that the Canadian population is graying. We're getting older. The baby boomer bulge that we've been waiting for has arrived. But at the same time as our population has gotten older, our population has also become more obese. And we have the dubious distinction of being in 4th place in the world as among the most obese countries after the US, Mexico, England, and then us. So obesity is crosstalks with aging. Metabolism slows as we age, and obesity is at least partly a byproduct of our aging, but certainly a lot of the lifestyle changes that have happened in a deleterious manner in our country have led to the obesity epidemic. Now, a lot of news media, hoopla, and certainly Hollywood starlets promoting the idea that GLP-1 agonists may be a fountain of youth and can reverse aging. Not sure I buy that, but certainly we'll talk a little bit about the fact that GLP-1 agonists may provide a target for mitigating some of the impact in select patients with obesity-related ASCVD. But certainly right now it's taken on a very prominent role in more cosmetic interventions, and sometimes we're actually struggling to get access to these therapies that can be so important in our diabetics and our ASCVD patients because it's sometimes being overused in a cosmetic application. But we know that the obesity epidemic has been growing, and the Canadian population, as much as 30%, are clinically obese, and by 2030, the estimates are that it'll be almost 40%. Almost 9% of the Canadian population as a result of obesity is now a type 2 diabetic, and that has been increasing by over 3% per year, the diabetic. Diabetes dramatically increases atherosclerotic events. We've known that for decades now. Hafner showed us back in the late 1990s that someone who is a diabetic but has no known coronary disease is at the same risk after 7 years of diabetes as somebody who's just had an MI and is not diabetic. If you have established cardiovascular disease and you're a diabetic, the risk of recurrent MIs are dramatically higher than in the non-diabetic population, and as much as 45 to 50% have recurrent events within a few short years in the Hafner data set. So certainly we know diabetes dramatically increases ASCVD. The problem has been that until very recently, traditional therapies, older agents, sulfonylureas, metformin, traditional therapies, even insulin, have failed to mitigate the macrovascular progression of disease. So MI rates were not lower in the granddaddy of diabetes trial, UKPDS, with aggressive DM control versus conventional therapy. At 10 years, there was no difference. So we have really had in the past ineffective strategies to mitigate the impacts of diabetes. And we have seen, though, in those same trials that those that can control their weight and lose weight, not only do they improve their A1C, they significantly improve triglycerides that we talked about that contributes to atherosclerotic disease, but in the Look Ahead trial, for example, and all subgroup analysis of other older DM trials, those that managed to lose weight had reductions in cardiovascular events. So there is clearly a big crosstalk between diabetes and type 2 diabetes and obesity, and strategies to mitigate obesity will not only potentially have impacts in type 2 events, but also ASCVD events. And we saw that with the GLP-1 receptor agonists. So, for example, in these two photomicrographs of trials with semaglutide and liraglutide in the SUSTAIN-6 and the LEADER trial, we saw that the subcutaneous GLP-1 receptor agonists reduced ASCVD events in diabetics quickly. The curves start to separate within a few months, and the longer patients are on the GLP-1 agonist, the lower the recurrent cardiovascular event rates. And similarly, we have seen with SGLT2 inhibitors that the addition of them in diabetics can reduce the risk of progression of heart failure and CKD quickly. Both GLP-1 agonists in particular, but also SGLT2 inhibitors do reduce weight to some degree, and there may be a crosstalk between weight loss and DM control in reduction of cardiovascular events. And so really SGLT2 inhibitors and GLP-1 agonists are the preferred anti-glycemic therapies in patients with ASCVD and diabetes. The older therapies like sulfonylureas do not mitigate cardiovascular events, and they should not be deployed as first line in these patients. First line therapies really should be targeting disease modifying anti-glycemic therapies. But we know, as we've talked about, that obesity is a contributor both to the development of diabetes, but also to the progression of atherosclerotic disease. We also recognize that obesity is a complicated mix of genetics, metabolic disorders, behavioral changes, and environmental factors. And it's certainly well beyond my capacity as a cardiologist to address those various aspects, but we really have to think about obesity management as a chronic disease management. We need to get past the pejorative nature of thinking about obesity that we have had for many years, decades in our population, to blaming patients for their weight. It is a chronic disease state that we need to provide support for and interventions to patients to try to mitigate the progression of disease because of the obesity epidemic. We know that obesity contributes to cardiovascular disease progression. It increases stroke rates, heart failure rates, MI rates, and the development of secondary risk factors. And so again, the impact of obesity reduction can have systemic benefits. And obesity accelerates atherosclerosis, both directly through reduced lipid turnover, but also indirectly through increased inflammation. IL-6, TNF-alpha, IL-1 beta all increase with obesity, and that increases endothelial damage. And we'll talk a little bit about inflammation in a few minutes, but certainly atherosclerosis progresses in that setting. So there is very much a crosstalk between obesity, inflammation, diabetes, and atherosclerosis progression. We've done a number of trials at trying to reduce obesity-related cardiovascular disease over the last 2-3 decades. Most of them have really failed. Both trials that have looked at lifestyle interventions as well as pharmacological interventions historically have really not reduced cardiovascular events. So a very large lifestyle intervention trial called the Look Ahead trial looked at very aggressive lifestyle interventions and really failed to show any reduction in cardiovascular events with this intervention strategy. The issue was that in this trial, even though patients had very detailed counseling and support and meal supervision, the weight loss was modest and there was a significant regain of weight. So lifestyle interventions have been challenging to mitigate. Obesity-related bariatric surgery, initially it did not show benefits, but with extended follow-up beyond 8 to 10 years, we see that atherosclerotic events are reduced in patients that undergo bariatric surgery to reduce weight, but it does appear to take time. At the beginning, as one may expect, there is actually increased cardiovascular events in the first few months, although it didn't reach statistical significance. The concern is obviously in that setting, if they have a ASCVD and they undergo such a large and major surgery like bariatric surgery, that events could occur during and post-operatively in the peri-surgical time. But over time, the weight loss that is achieved with bariatric surgery does appear to reduce cardiovascular events after a number of years. So up until very recently, bariatric surgery was really the only intervention that was shown to reduce events. Various pharmacological therapies that have tried to address the different mechanisms of obesity development have failed historically to reduce ASCVD events, whether they target the neurocognitive, behavioral, or the inflammatory mechanisms of obesity historically have failed until the SELECT trial. So GLP-1 agonists, receptor agonists, seem to have a very important role to play in mitigating cardiovascular complications, both in diabetics as well as I'll show you data now in the non-diabetic population with obesity. They clearly improve glucose metabolism. They result in significant weight loss. In the diabetic patient population, as I showed you from the results of SUSTAIN-6 and LEADER and other trials that have been done, MACE events are significantly reduced, at least in part due to the reduction of inflammation, improved lipid profile, and the atherosclerotic benefits therefrom. We studied this in a very large trial, which is a seminal trial in one of the landmark trials of the last decade called the SELECT trial, and I was very honored to be a principal investigator in the trial. Our center was actually the largest recruiting center in North America in the trial, outside of one, I think, in California, so the largest in Canada. So I take a lot of pride in the results of SELECT. And what we did in this trial was we randomized patients without diabetes, but with obesity and cardiovascular disease to best medical therapy, but added semaglutide in one part of it and placebo in the other. And what we showed is that the addition of semaglutide, or the brand name Ozempic, resulted in significant reductions in major adverse cardiovascular events. All three components, cardiovascular death, cardiovascular MIs or strokes, were significantly reduced by 20%. And again, curves separate quickly and continued to separate the longer patients were on it. each of the individual events were reduced. Now you'll see what's interesting in this graph is that in the middle there, between 18 to 30 months, the curves actually appear to come back together and then separate again. And that's a phenomenon of this trial. This trial was conducted in the middle of the pandemic, the COVID-19 pandemic. It was incredibly difficult to do this trial and continue it while we were in lockdown. And during that time, obviously patients were dying of other things that were not necessarily related to their atherosclerotic disease, or perhaps even related, but more triggered by the COVID-19 virus. So we saw during the pandemic that the curves actually started to come back together. But again, once we got past that, curves separated again, and we saw significant reductions in both cardiovascular death and heart failure in patients that were randomized to semaglutide versus placebo with obesity on top of best therapy. And importantly, cardiovascular, but also all-cause death was significantly reduced by almost 20% in those that were on semaglutide. So we finally have an intervention that does substantially reduce cardiovascular events in obese patients with ASCVD, and we seem to get benefits quickly, and it is now indicated potentially in ASCVD patients. There's another very large trial ongoing right now, which is looking at a GLP-1 combo, tirzepatide, which appears to result in even greater weight loss. We're waiting for this SURMOUNT MMO trial to finish. This is again randomizing patients to best medical therapy, but the addition of tirzepatide versus placebo in morbidly obese patients with established ASCVD. So that should hopefully present in the next few years. There's a number of other trials with other molecules ongoing. This is a huge area of exciting development, so more to come. But certainly the SELECT trial, landmark trial that changes our understanding of both obesity and the progression of atherosclerotic disease. I will be fortunate to be presenting at the Canadian Cardiovascular Society in a couple of weeks the impact of semaglutide on inflammation and progression of cardiovascular disease from the SELECT trial. And as a teaser, what we showed in this analysis is that the addition of semaglutide substantially reduced weight as we expected, but also reduced hsCRP, which is, as you know, a marker of vascular inflammation, and potentially one of the mechanisms by which semaglutide may reduce cardiovascular events is through its reduction of vascular inflammation, which then brings us to a topic to talk about is the role of systemic inflammation as a driver of ASCVD, both in the obese population, but also in the non-obese population. We know that vascular inflammation increases atherosclerotic events. LDL is atherogenic, but once the LDL becomes oxidized, it is even more atherogenic. It is much more prone to enter the endothelium and cause subendothelial injury and lead to plaque progression. And we have had hsCRP available to us for a number of years as a marker of potential vascular inflammation. So CRP, as you know, is an acute phase protein produced in the liver when there are elevated circulating cytokines like IL-6 and TNF. It is by itself not a causal agent, but a marker of disease progression in ASCVD. And in cardiovascular risk assessment, we use high sensitivity CRP, hsCRP. The traditional CRP marker isn't sensitive enough to detect vascular inflammation. And so when we think about CRP, we really put it down into standard CRP assays that are used for systemic infections or inflammatory conditions. Standard CRP measures CRP above 1 milligrams per deciliter. High sensitivity, or hsCRP, is developed specifically to measure levels that are present in vascular disease and atherosclerosis. So hsCRP looks at much lower levels of CRP elevation between 1 to 10 milligrams. And if the CRP is significantly above 1, certainly above 3, that does substantially increase the risk of cardiovascular disease. We've shown that in both primary prevention, that those that have an elevated CRP have significantly higher, as much as 40% higher risk of cardiovascular events, regardless of their blood pressure or cholesterol. So HSCRP is a potential screening tool to determine those that may be at increased cardiovascular risk and require aggressive risk factor optimization in a primary prevention population. But in a secondary population, if they've had a cardiovascular event, various trials have shown across the world that elevated CRP, HSCRP, can increase recurrent cardiovascular events anywhere between 40% and, in one large trial from China, as much as 250%, but certainly a substantial increase in cardiovascular events despite optimum medical therapy if there is ongoing evidence for atherosclerosis inflammation as measured by HSCRP. And we have had biological data from animal studies that target IL-6 production, one of the main vascular inflammatory mechanisms, that the IL-6 reducing therapies in animal models have reduced the progression of atherosclerotic lesions substantially, as you can see on the left in the mice model. And we have had now 4 large clinical trials looking at trying to reduce vascular inflammation. CANTOS, that I was fortunate to be a part of, COLCOT, LODOCO-2, and CERT, and we'll talk very briefly about that. So CANTOS was a trial that looked at an immunomodulating therapy, canakinumab, substantially reduced CRP, and in the CANTOS trial, we showed a significant reduction in major atherosclerotic cardiovascular events within a few years. The molecule didn't make it to market, mostly because those that were randomized to canakinumab, unfortunately, also had increased risk for infections and sepsis, leukopenia, and thrombocytopenia. So as a result, despite its reductions in MACE, because it had off-target effects and increased non-cardiovascular events, canakinumab did not make it to market for cardiovascular disease. Now, interestingly, canakinumab did reduce lung cancer and other cancers potentially, and it is being looked at as an anti-cancer therapy, but is not part of our armamentarium for cardiovascular risk reduction. Now, COLCOT and LODOCO-2 have looked at a commonly available anti-inflammatory colchicine, which is often used in gout and other arthritic inflammatory conditions. And the addition, and COLCOT was actually a very large Canadian trial led by the Montreal Heart Institute. And in COLCOT, what we showed is that those that were on colchicine had significant reductions in cardiovascular events. This was proven in the LODOCO-2 trial. So colchicine in select patients with elevated markers of inflammation may have a role to play and reduce risk between 23 to 30%. CERT was a trial that looked at using methotrexate, which, as you know, is often used in arthritic conditions, rheumatoid arthritis, at low doses. Unfortunately, the doses that were chosen did not reduce inflammatory marker CRP, didn't reduce HSCRP, and the doses that they studied in the trial, and we did not see any reductions in cardiovascular events. So unless you reduce the inflammation, you're not going to reduce the event you're trying to reduce. So certainly right now, the one therapy available to us with persistent inflammation in ASCVD patients is colchicine. There is a very important molecule in development, zevaleucumab, zevaticumab, I can't even pronounce it properly, which is a fully human monoclonal antibody that targets the IL-6 ligand, which, as you remember, is what leads to the LDL oxidation and leads to progression of atherosclerosis in various models. And this molecule is being studied in 3 very large trials that I'm fortunate to be a PI on. The ZEUS trial in ASCVD patients and CKD patients, because it may also mitigate renal disease progression. The Hermes trial that's looking at heart failure with preserved ejection fraction, and the Artemis trial that is looking at it in a very large population of post-MI patients. So this data will start to come out in the next couple of years, and we may have an even more potent anti-inflammatory mechanism to reduce cardiovascular risk. I want to finish by just talking very briefly about the impact of cardiovascular disease in women, because we're seeing the most rapid increase in cardiovascular events in women. And we know that cardiovascular disease is now the leading killer among women worldwide. Women are 6 times more likely to die of cardiovascular disease than breast cancer. Every 20 minutes, a Canadian female will die of heart disease. But 2/3 of the research up until now in cardiovascular disease is exclusively focused on men, and we've had very limited trial data to understand the mechanisms of cardiovascular disease historically, and we've underestimated cardiovascular disease in women. And what we've seen in terms of demographic trends, that women since actually the mid-1980s have had at least as high a mortality from cardiovascular disease as men. And in more recent years, as we've seen substantial reductions in cardiovascular mortality in men, we have not seen that same reduction in women, although we are perhaps starting to see the curves come down in women. But there is now actually more women that will die of cardiovascular disease than men, particularly in the postmenopausal years. So, we know that cardiovascular disease is common in women. Unfortunately, the most common presentation for a woman with cardiovascular disease is an MI. 60% of women will present with ASCVD as a heart attack, which makes it complicated. How do you prevent that? Well, certainly one of the issues is to try to find those early warning signs, and in populational studies, as much as almost 80% of those women that had a heart attack had warning signs ahead of time that were missed, that could have perhaps mitigated some of that risk. Women are less likely than men to seek medical attention when a cardiovascular disease event is occurring, because they're less likely to seek help, but also because the biases that are intrinsic to our healthcare system. There is very much a gender bias. They often do not receive timely diagnosis for their cardiovascular disease, and events occur more commonly in women. We also know that the risk factors that lead to cardiovascular disease in men also lead to cardiovascular disease in women. 80% of the risk of heart disease in women is accounted for by the traditional risk factors that we know about, but some of those risk factors have a much greater effect on women than in men. Smoking, diabetes, psychosocial stress, for example, have a 200% higher risk of leading to cardiovascular disease in women than in men. So certainly we need to be much more aggressive in our assessment of cardiovascular risk in women and trying to mitigate that risk early. But there are some very sex-specific risk factors that we need to be aware of, and we need to actually start asking about when we're doing our cardiovascular risk assessment. Just like I ask about, are you diabetic? Do you smoke? Do you have high blood pressure? I need to start asking, have you had polycystic ovarian syndrome? That significantly increases risk in women. Particularly just pregnancy-related complications substantially increase risk. Gestational diabetes, placental abruption, premature delivery, stillbirths, all of those types of pregnancy complications substantially increase the risk of future cardiovascular events. Similarly, premature menopause increases risk by almost 95% of future cardiovascular events. So in our history taking, we need to now add these as risk factors in women and understand that women that have these sex-specific risk factors are at a substantially greater risk and require more aggressive risk factor reduction strategies to help mitigate that risk. There are also, it turns out, multiple causes for MIs, both in men, but particularly in women. We know that the vast majority of women will end up with MIs through the traditional plaque formation, plaque rupture events, ACS, that we send our patients for cath and stenting for. But women more commonly than men, but also in men, we know that there are other causes of MIs. Coronary vasospasm can be a common cause for MIs in women. Spontaneous coronary artery dissection is much more common in women and again leads to myocardial infarctions. And stress-related, what we call Takotsubo cardiomyopathy, where high surge of adrenaline through various stress mechanisms leads to an acute myocardial injury and cardiomyopathy, again more common in women but also present in men. So we need to think past our traditional atherosclerotic risk factors, particularly in women, and try to understand that the disease can occur in various mechanisms. Not all angina in women is due to obstructive proximal coronary artery disease. Microvascular coronary dysfunction is much more common in women than in men and can cause symptoms identical to obstructive coronary artery disease mediated angina. And so microvascular disease is in fact a common cause for anginal chest pains in women, also men, but more commonly in women. So we really need to think more broadly about our definitions of cardiovascular disease, particularly in women. So I want to conclude now by just summarizing that we have had very effective therapies to reduce cardiovascular one-year mortality with the use of antiplatelet therapies, statins, ACE inhibitors, beta blockers, and when we deploy those strategies, as much as 90% of the one-year mortality can be reduced. The issue is that the disease continues to progress in the background despite guideline-directed medical therapy. And at 3 years, as much as 15% of patients have had another event like cardiovascular death, MI, or stroke. And so it's really about trying to reduce that residual progressive risk that we need to think past our traditional therapies and to have very phenotypic specific personalized care models. Not everybody needs everything. We certainly want all of our patients on antiplatelets, statins, ACE inhibitors or ARBs, and at least for the first year, beta blockers, perhaps longer. But beyond that, certain individuals require other therapies to reduce that progressive process. And there are a number of therapies that have now become available. It is becoming more complicated. We have created at Cambridge Cardiac Care Centre a residual risk calculator and management guide that you can just Google or go to our website. It is a very simple tool. We published data on its efficacy 2 years ago, showing that this web-based application can both identify residual risk and through an AI algorithm in the background, it actually helps to determine optimum therapies. It's a very simple risk calculator. You just enter in some risk factors. It will determine the residual risk of the patient compared to those that have been fully optimized. And then using an internal algorithm that's constantly updated as new data comes out, specific recommendations is generated by the AI. So what should be considered for mitigating risk, whether it's lifestyle interventions, specific therapies, and it gives the citation for it so you know what the reference is that really tells us to deploy that strategy. So certainly anyone who is looking for that, that's through our website, cambridgecardiaccare.com/calculator, and that can be a tool that can help to identify those patients that may benefit from additional therapy. Now, certainly with the complexity of it, a number of our regional physicians have asked us to create a clinic to help them optimize this, and about a year ago we launched an ASCVD risk factor optimization clinic. It is open to referral on Ocean and really tries to identify those patients that can benefit from more aggressive lifestyle intervention, but also optimization of pharmacological therapies where required. So certainly that's open to anyone for referral. This is a nurse-led clinic that should hopefully provide a bit of resources. So at this point, I'll stop talking and just open this up to any questions that may stem. Thank you so much for inviting me to present.
So thank you. That was a lot of data. I'm just scanning the chat and I don't see any hands up. So maybe I'll start with, Kristen, we have a question. Dr. Wadsworth, if you want to ask, go ahead.
Yeah. Awesome. Thank you so much. This was great. I am one of the gynecologists in town, and I was just wondering if you could kind of comment on anything in terms of menopause hormone therapy and helping to reduce cardiovascular risk. I know that our guidelines in Canada right now are not saying that this should be the reason that postmenopausal women are on MHT, but I just didn't know from a cardiac perspective what your thoughts on that are.
Yeah, excellent question. So, certainly going back in time, there was a big expectation that hormone replacement therapy may help to mitigate or reduce some of the increased risk in women postmenopausally. In the large trials that were done about a decade plus ago, we did not see the event reductions that we were expecting and did see potential increase in pulmonary embolism and malignancy link. And so certainly right now it's not recommended as part of the ASCVD risk reduction strategy. Historically, we used to strongly discourage its use. Now there's perhaps a more nuanced approach that we have to really think about it more globally as to what the impact of hormone replacement therapy in other systems, certainly fracture risk and other chronic disease progression that we need to think about more broadly. And there are actually some more very specific molecules I think in development and being studied that may have some potential benefits that can be modified versions of hormone replacement therapies that are being studied. But certainly right now, the guidelines are still certainly for prevention of cardiovascular disease. It's not a part of our treatment armamentarium. But as I said, for a little bit there, we were very aggressively saying that it shouldn't be on it. Now I think we're being a bit more nuanced to suggest that, I think we need to be very specific to that individual. What is their overall global risk for other disease conditions, and how does that balance out with the cardiovascular risk?
Thank you for that. Dr. Didick, you had a question.
Oh, hi. Thank you for that. I did put my question in the chat. I just really appreciate your excellent review. And I wonder if you can comment on how we should, if we should, and how we should tailor lipid management for some of the frail old, because I tend to think more about pill burden and that. So I'd appreciate your thoughts. Thanks.
Yeah, no, very, very good question. So obviously, as individuals age and in the elderly population, polypharmacy becomes a very big challenge, and certainly you address that quite commonly. We've now studied statins across the spectrum of age, and actually in the most recent PCSK9 trials, for example, patients were enrolled well into their 90s. And when we look at ASCVD event reduction, both with lipid-lowering therapies, but also with antihypertensives, for example. We know that not only do we reduce mortality, even in an elderly, extreme elderly population, but we also reduce morbidity quite substantially, particularly progression of heart failure and the morbid complications of heart failure, but also stroke risk reduction substantially, and the neurocognitive impact of that, obviously. So certainly, I think it does come down, in my mind, to goals of care in that individual that's in an extreme elderly population or frail population. If there is a significant life expectancy beyond a few months, there may be both mortality, but more importantly, often for the extreme elderly, morbidity reductions with risk factor modifying therapies, particularly reductions of stroke and heart failure reductions by continuing therapies to reduce both blood pressure and cholesterol control. But I think that's one of those things that obviously you gear your approach to, which has to be very individual specific, patient specific as to what the goals of care are and how some of those therapies may have off-target effects or impact risk of other things. Now, interestingly, in the SPRINT trial, for example, that looked at very aggressive blood pressure control versus looser blood pressure control. So that's the trial that taught us, for example, that the new target for blood pressure in high-risk patients should actually be a blood pressure target below 120/80. Those that were randomized to 120/80 had significant reductions for both strokes and heart failure, regardless of age. And even in the octogenarian population, there were significant reductions in heart failure and stroke risk. And importantly, one of the concerns going into the trial was, would it result in a lot more falls and hip fractures? And we did not see that in the trial. There was no increase in falls or stroke risk. So I think it really has to be more individualized and more nuanced as to how we think about these types of therapies in that elderly or extreme elderly population.
Thank you. Thank you, Dr. Kennedy. There are two questions left, and I will try to get to those, but acknowledging that it is now 9 o'clock and some people do have to go, I just wanted to thank you for this great presentation. And just to remind everyone that if you have not logged in under your own name, please let Nina know so that we can get you your CME credits. And Dr. Pandy, if you have 2 more minutes, I will do the last 2 questions.
Thank you.
The first was in the chat, just asking if you could provide some of the names that people might be familiar with for the lipoprotein A disease-modifying agents.
So certainly right now in lipoprotein A, there's no approved therapies for lowering lipoprotein A, but in patients that require PCSK9 inhibitors for LDL reduction, we do see 20 to 30% lipoprotein A reduction. So the PCSK9 inhibitors that are available in Canada are evolocumab, which is Repatha, alirocumab, which is Praluent, and we now have a modulator, Leqvio, which is once every 3 to 6 months. And significantly lowers LDL, but all 3 of those molecules do lower lipoprotein A. They don't have an indication in Canada specifically for lipoprotein A lowering, but certainly in patients that have a need for further LDL reduction and they have an elevated lipoprotein A, I think we get a double benefit of adding in a PCSK9 modulator or inhibitor like Repatha, Praluent, or Leqvio. There are, I think, as far as I'm aware, 4 molecules that are in development specifically to lower lipoprotein A, and in phase 2 trials have lowered lipoprotein A by as much as 80%. We're now waiting for the event trials to get done to ensure that reducing lipoprotein A does reduce MIs and strokes. So that will come up, but that's currently what's available, the PCSK9 modulators or inhibitors.
Thank you. And Dr. Feldman, you had a question.
Yes, thank you so much. Thanks for taking the extra time as well. I'm a pediatric endocrinologist actually, and doing diabetes care kind of throughout the GTA as well. My question is kind of around like if there's anything from the research kind of speaking to the like kind of 18 to 25-year-olds. See several patients with premature ovarian failure. We'll see patients with PCOS, but really for the POI patients, we'll be starting estrogen for pubertal development, and we speak about cardiac protection as well, but wondering if there's been anything in the research and the literature that's kind of spoken to that population, or kind of that, anything else we should be considering for cardiac protection over the long term from such a young age.
Yeah, no, excellent. Thank you for that question. Obviously, you're going to be much more versed in some of that data than myself. It's not a population that I see exclusively, but certainly we know that premature ovarian failure substantially increases cardiovascular event rates over the lifetime of those women. And I think particularly when premature ovarian failure happens so early through PCO and other ovarian failure syndromes, we need to be very aggressive about trying to mitigate that risk. I'm not aware of any specific trials that have looked at that population per se, but certainly my approach in that setting would be, I would defer to an endocrinologist like yourself as to the role of hormonal replacement therapies, but other risk factor modifying therapies, I think we have to be aggressively on top of. As if their LDL starts to rise, I think we need to be aggressively trying to address that. We need to, often these patients, as you know, are more prone to developing hyperglycemic states and more prone to developing type 2 diabetes, and we need to stay on top of that. The potential impact of GLP-1 agonists in that setting is, I think, being addressed, and there's actually a couple of trials that I'm aware of that are ongoing right now, specifically looking at that population with GLP-1 agonists. But certainly, in other sort of systemic processes like we didn't talk about it today, but with NASH, or what we now call MASH, so the steatohepatosis, fatty liver, we have shown with GLP-1 agonists that that they can potentially reduce fatty liver disease progression, but also those are patients that are at a much higher ASCVD risk, and GLP-1 agonists may reduce some of that risk as well. And premature ovarian failure patients, from my understanding of it, and you would know better, are, I think, at an increased risk for MASH-based complications as well. So I think we do need to do a lot more studies in that population, and some of that will come. My approach is to be an all-hands-on-deck approach, that I consider those individuals to be at a much greater lifetime risk for cardiovascular events, and from an early point on, really stress the impact of optimum lifestyle interventions, but where necessary, deploy other ASCVD risk-reducing traditions.
Trailed off there. I'm not sure if it's on my end or your end, but you do appear frozen on my screen, so I apologize if I've interrupted. Thank you, everyone, for your attendance this morning. Thank you very much to Dr. Pandy for not only sort of volunteering to take over this talk, but to just being able to sort of present a talk that I think actually targets all of the various subspecialties who attend. So I think this is great. So thank you, everyone. Have a great day, and welcome to fall.